Hello and welcome to Talking About Tumors with Ryan and Ryan. I'm Ryan Holstead.
And I'm Ryan Quinn.
And today we're going to continue our discussion around renal cell carcinoma, today talking about the advanced and metastatic setting.
So metastatic renal cell carcinoma is a pretty heterogeneous disease. Some people can actually do pretty well with just surveillance alone, whereas others need more rapid treatment due to symptoms.
Yeah, it's a very fascinating disease. I've seen at least one patient who I met after 3 years in the metastatic setting who never saw any systemic therapy. And over the following 2 years, we continued to be able to observe. And although the lung lesions grew gradually, they never became symptomatic during the 2 years that I knew the patient. On the other hand, I've seen patients present with extremely aggressive metastatic setting, losing 40 pounds or greater over the span of 3 months with widely diffuse disease at the time of presentation. Given this variability, there's certainly an art in the management deciding what to do and when to do it in the metastatic setting, especially given that this is a tumor that can be approached in the oligometastatic fashion if we're able to completely resect, ablate, or radiate all the areas of metastatic disease.
Initially, this was one of the rare cancers where even in the metastatic setting, you remove the primary tumor, something called cytoreductive nephrectomy. This became popular in the era of interferon, which is not currently used, and the data for this in the era of modern therapies is lacking, so not routinely done anymore. But classically, even in people with metastatic disease, they would have a nephrectomy to remove the primary tumor. And it actually did show improvement in overall survival. Again, in the era of interferon, so not using the modern therapies that we're using now.
There were 3 landmark trials that were run looking at this question, giving patients interferon alpha alone or interferon alpha and surgical removal of the primary tumor. And a meta-analysis of this that published out in 2004 did show improvements in median overall survival, about 13.5 to 7.8 months. The hypothesis at the time was that the primary tumor had some role in driving the development of new metastases and disease behavior. Interferon alpha was highly toxic and not overly effective. However, the best we had is these tumors are naturally chemotherapy resistant. But as systemic therapies advanced and we began to use the drugs such as sunitinib and sorafenib targeting the VEGF system, we have not been able to redemonstrate these improvements in survival with nephrectomy in the metastatic setting. Some initial studies which were performed retrospectively found that patients who had nephrectomy tended to live longer than those who did not, but the issue with all retrospective studies is patient selection. And we're probably more likely to offer nephrectomy to a younger, healthier person. And even when we do our best to balance for differences in patient behaviors, retrospective study is not as good as a randomized control trial to answer these questions. In fact, there were 2 randomized trials that were done prospectively, one called the CERTIME trial, which was not able to enroll enough patients, and the Carcinoma trial, which compared cytoreductive nephrectomy to sunitinib alone, which was a study run in France.
And this trial showed non-inferiority to sunitinib alone rather than sunitinib plus nephrectomy.
Currently, this is not an approach that would be done commonly. However, as we had discussed during our last discussion, and given the role of adjuvant pembrolizumab for patients with completely resected metastatic disease, we may still see nephrectomy done if we can obtain complete resection of an additional 1 or 2 metastatic deposits. Once a patient has 5 or more metastatic sites of disease, you're less likely to see a complete surgical resection, and the role of cytoreductive nephrectomy in that case is likely of limited benefit. Because renal cell carcinoma can have such a wide variety of presentations and behaviors, in order to decide upon how aggressive we want to be with our therapy and to try to best describe the natural history of an individual patient's cancer, risk scores have been developed to try to predict prognosis based upon some presenting features.
Probably the most well-known of these is the IMDC, which is the International Metastatic Renal Cell Carcinoma Database Consortium score, and this prognostic model includes 6 factors. The first one being the patient's performance status, which is defined as the Karnofsky performance score less than 80%. The second one being the duration of diagnosis to treatment being under 1 year. The third one being hemoglobin less than lower limit of normal. Number 4 being calcium greater than the upper limit of normal. Number 5 being ANC greater than the upper limit of normal. And the last one being platelets greater than the upper limit of normal. If you have none of these risk factors, that's considered favorable disease. 1 or 2 is considered intermediate risk, and 3 or more is considered poor risk.
This risk score was developed looking at the prognosis in patients who were being treated with sunitinib and correlated closely with overall survival in this patient population. These risk factors selected are both demonstrating aspects of patient factors, such as performance status, as well as tumor factors, such as the paraneoplastic findings of anemia, hypercalcemia, leukocytosis, and thrombocytosis. The interesting factor is the time from diagnosis to treatment, and this is generally with the idea of a patient having a nephrectomy for localized disease and the length of time before the disease recurs and systemic therapy is indicated. However, you could also use it as a justification from the time of diagnosis, even if someone presents with metastatic disease, to the time of significant enough progression being identified to justify initiating systemic therapy. The time from diagnosis to treatment is probably the most vague of the risk factors. Memorial Sloan Kettering Cancer Center has also developed their own cancer score, which has been validated in a similar manner and includes pretty much the same factors, which includes once again the Karnofsky performance status, anemia, hypercalcemia, time from diagnosis to treatment. The MSK score does not include an elevated ANC or thrombocytosis, but it does include LDH. And you may see one or the other being used as a risk stratification factor in clinical trials. Obviously, these aren't the best ways of describing a cancer, and ideally we'd have more accurate biomarkers, such as tumor characteristics. And although tumor characteristics such as clear cell pathology, sarcomatoid pathology, as well as tumor grading may help demonstrate how the cancer behaves, none of these have been validated as well. And it may be a number of years before more specific biomarkers emerge to help risk stratify our patients.
So for patients with favorable risk disease, so patients with none of the risk factors in the prognostic models, if they're asymptomatic and have a limited disease burden, then close active surveillance is the recommendation for treatment. And these patients can be followed by scans every few months. And there was actually a study that in people with low risk disease, there was actually an average of 22 months before they needed to initiate therapy. And this allows you to avoid the toxicities of treatment until the patient really needs it.
So getting into the systemic therapies for renal cell carcinoma, as mentioned during our previous discussion, the backbone of therapy comes in two forms, either immunotherapy or VEGF-based targeted therapy. The first treatment to move into the metastatic setting, as we have just discussed, was interferon alpha. This was a drug used to basically lead to a cytokine release, with the idea of leading to an overall immune system stimulation. Although this did have benefits over placebo, it was a fairly lousy drug and didn't have long-term survival, had a high degree of toxicity, and was restricted in which patients it could be used for. Sunitinib was one of the first oral agents to target the VEGF pathway. This is what we consider a dirty TKI and also has multiple targets other than just the VEGF receptor. Even though this drug is not considered to be our standard of care in the first line setting, I think it's worth just briefly discussing how it came to approval and some of its toxicities, because it remains the control arm for many of the studies that are continuing to publish out at this time. The landmark trial that got this approved was published in 2007 in the New England Journal. And this was a randomized controlled trial comparing sunitinib to interferon alpha. The primary endpoint was progression-free survival with 90% power to detect an improvement of progression-free survival by about 2 months. So from 4.7 months, which was previously shown as the average in interferon alpha, to 6.2 months. 375 patients were in either arm, and this was a positive trial, improving progression-free survival from 11 versus 5 months, and this did end up showing an improved overall survival of 26 versus 21.8 months. In this study, sunitinib was given as a 15 milligram dose daily for 4 weeks on, followed by 2 weeks off. This is relatively toxic with a high degree of diarrhea, grade 3 being 5% in the sunitinib arm, fatigue being 7%, and also a high degree of stomatitis, which all grades came out at 25%, an increase in blood pressure of 25%, a risk of hand and foot syndrome, a risk of bleeding and thrombosis. So the bleeding, thrombosis, hypertension, very similar to what we've seen with bevacizumab, whereas the stomatitis, hand-foot syndrome, and diarrhea being more from its off-target non-VEGF toxicities. Should you still be using sunitinib in your practice? It's worth knowing that there are different ways of trying to manage this drug to maximize toxicities. You can either go down on the dose of the drug, and many providers will modify this 4 weeks on, 2 week off regimen. So you may see patients get 3 weeks on, 2 weeks off, 2 weeks on, 2 weeks off, and we try to find the best duration and dose that can be tolerable, because the patients will be on this for long term, as long as it's being tolerated and efficacious. We're going to now discuss the modern immune checkpoint inhibitor trials. It's worth mentioning that many other tyrosine kinase inhibitors had been studied versus sunitinib or studied after sunitinib, had gotten approved, and this all occurred in the mid-2000s to early 2010s. And these all have fairly similar toxicity profiles. They may have more or less of individual toxicities depending on which target they inhibit more or less of, as well as may have different drug interactions. So you may hear of drugs like lenvatinib, axitinib, pazopanib, cabozantinib, as well as others. For the sake of brevity here, we're going to focus on a couple key trials, but certainly worth reading up and being aware of the other drugs that are out and may be approved wherever you work.
So as Ryan said, there's many different VEGF inhibitors, and there's also many different VEGF inhibitor and immunotherapy combinations, such as pembrolizumab axitinib, nivolumab cabozantinib, or pembrolizumab lenvatinib. We won't get into all of the trials because they're all pretty similar and they all are compared to sunitinib. But to go over one of the larger studies with pembrolizumab and axitinib, which is Keynote 426, this study included almost 900 patients and randomized patients to either the combination of pembrolizumab, 200 milligrams every 3 weeks for up to 2 years, with the combination of axitinib daily. And this was in comparison to sunitinib, which was the standard of care at the time. Looking at overall survival, this was improved with the combination of pembrolizumab and axitinib. 5-year overall survival was 42% versus 37%, with a hazard ratio of 0.84. And 5-year progression-free survival was 18% versus 7%. There was also increased response rate. There was also increased overall response rate with the combination arm, which was 61% versus 36%. When they looked at patients with favorable risk versus intermediate or poor risk, the favorable risk didn't really have much of a benefit with the combination arm. 5-year overall survival 50% versus 52%, and this was not statistically significant. However, the intermediate or poor risk patients did have an improvement in overall survival, which was statistically significant. 5-year overall survival 38% versus 30%.
These translated into median overall survivals in the favorable risk group as 60 months in the combination group versus 62 months in the sunitinib group, and in the intermediate to poor group being 42 months versus 29 months respectively.
Some of the common toxicities that are seen with this regimen are diarrhea, hypertension, elevated liver enzymes. It can be difficult to distinguish between if the toxicities are coming from the VEGF inhibitor or the immunotherapy. And one of the ways to help distinguish this is if you hold treatment and see if it improves. For example, diarrhea, if you hold the VEGF inhibitor, that should improve pretty quickly on its own, whereas immunotherapy usually persists unless you start steroids. But it can sometimes be tricky to tell which drug is causing the side effect.
All of the other combination VEGF-based tyrosine kinase inhibitor and immune checkpoint inhibitor versus sunitinib trials, of which there's been at least 4 equivalent studies that have since published out, and at least one more that's still continuing to run, and have all been compared to sunitinib, have quite similar findings. Furthermore, a meta-analysis of all these trials was unable to show any improvements in survival in the favorable risk group. So it does remain an ongoing area of debate for favorable risk patients whether or not they warrant the doublet therapy up front. The argument for this is that it may delay progression, and in certain patients that could be beneficial. The argument against this being it's not shown overall survival and does come with additional toxicity and patient costs. One of the quite unfortunate things here is we've had multiple studies with close to 800 plus patients in each individual trial, which means we've had thousands of patients randomized to sunitinib, and all these trials have ended up showing the same answer. Unfortunately, with these Me Too trials, we don't often have coordinated questions being asked. And looking back at this, there does seem to have been a missed opportunity to ask certain questions about different biomarkers, as well as trying to answer which combination is the best combination. And I think it's unlikely we'll get those answers anytime soon with the way that those studies are run and the fact that most of them are now complete at this point.
There's also been approval of the immunotherapy combination of ipilimumab, the CTLA-4 inhibitor, with nivolumab, the PD-L1 inhibitor, rather than using the combination of immunotherapy and a VEGF inhibitor. This study, Checkmate 214, was a phase 3 trial looking at approximately 1,000 patients who were previously untreated, looking at the combination of ipilimumab, 1 milligram per kilogram, and nivolumab, 3 milligrams per kilogram, given every 3 weeks for 4 doses, who then continued on to receive just the single agent nivolumab every 2 weeks for up to 2 years. And this was randomized against sunitinib as a control arm, 50 milligrams daily, 4 weeks on, 2 weeks off, every 6-week cycles. So this did show an improvement in 5-year overall survival with the combination immunotherapy arm, 48% versus 37% at 5 years with a hazard ratio of 0.72. However, this was only seen in the intermediate or poor risk patients, where the 5-year overall survival was 43% versus 31%. In the favorable risk patients, there was not a statistically significant overall survival benefit.
The study was designed in such a way where the intermediate and poor risk patients were the primary focus and was considered a positive trial. Median overall survival is 52 versus 38 months in the intermediate and poor risk patient group.
So due to this is an option for patients with intermediate or poor risk disease. It does come at increased toxicity, so it would really only consider this for the highest risk patients.
One unique histopathology of renal cell cancer is the sarcomatoid pathology. These have seemed to be more sensitive to immune therapy and would be preferential to use nivolumab and ipilimumab if there's no contraindications.
Most patients will have been treated with the combination of immunotherapy plus VEGF inhibitors in the first-line setting. If for some reason patients didn't receive immunotherapy in the front line, you can use single-agent immunotherapy in the second line or the combination of ipilimumab, nivolumab, as we just discussed. If patients have never seen a VEGF inhibitor, then that's certainly an option in the second-line setting as well. There's also the ability to change the VEGF inhibitor. For example, if you started with pembrolizumab and axitinib, and there's progression, you can change to an alternative VEGF inhibitor, such as lenvatinib or cabozantinib.
Other approved agents include tivozanib, and sunitinib still remains an option. The idea here is to try to pick a different TKI, which might have a different predisposition for the other receptors, which could potentially get around a point of resistance. Another drug that has shown efficacy, although at the cost of significant toxicity, is everolimus. This has been studied both in combination with lenvatinib as well as on its own. Doesn't seem to add overall survival benefit versus lenvatinib, so you'll more often see it being given as its own. This, like the other agents, can have a high degree of toxicity, primarily with everolimus, mucositis, hand-foot syndrome, nausea, vomiting, diarrhea are what you would experience. Most recently, the newest drug to show efficacy for these patients is a first-in-class molecule. So this is belzutifan, which inhibits HIF-2alpha, so our hypoxia-induced factor. If we remember all the way back to the start of the last discussion, this is one of the primary protein involved with tumorigenesis in patients with von Hippel-Lindau, and the von Hippel-Lindau mutation being present in the vast majority of patients with clear cell renal cell cancer. After some initial early phase efficacy, this was studied in a phase 3 trial in patients who've at least been exposed to a PD-L1 inhibitor as well as a TKI. They had to be anywhere in the 2nd to 4th line of systemic therapy. So randomized controlled trial that randomized patients on one arm to belzutifan, 120 milligrams given daily, or everolimus, 10 milligrams given daily. There's 370 patients in either arm. The primary outcomes for this trial was progression-free survival and overall survival. Interestingly, the median progression-free survival was the same between both groups at 5.6 versus 5.6 months. However, the hazard ratio was 0.75. How did the median stay the same, but the hazard ratio was improved? Well, those patients that did respond have a longer duration of response. So the curves stayed close together for the first 5.5 months and then began to separate after the 6-month point. Overall survival was improved, although this did not yet meet statistical significance, but the median overall survival is 21.4 versus 18 months, with a hazard ratio of 0.88. This has since gained approval, at least in the United States, and given the significant toxicities with everolimus and improved progression-free, as well as a trend towards improved overall survival, is an interesting option to consider. Given being a new type of drug, it does come along with a new class of toxicities. And there was a great discussion around this agent at the ASCO 2024 and its unique toxicities, which are worth mentioning. Because this inhibits hypoxia-induced factor, which plays a role in erythropoiesis, the major side effect is anemia. And 80% of patients exposed to this drug develop anemia, 30% of whom develop grade 3 anemia, which is anemia requiring transfusions. 15% developed hypoxia, and 10% of these patients were grade 3 hypoxia. There was also fatigue, edema, nausea, vomiting, and diarrhea of note. During the discussion at ASCO, Dr. Jonash had recommended to all of his patients that start on this drug to buy a pulse oximeter and monitor oxygen at home. Any patients whose oxygen drops below 90% will need to have the drug held until oxygen levels recover, and then will often need a dose reduction. Also, for patients developing anemia, one could consider erythropoietin agonists if you have access to those, such as darbepoetin. It is very important if you're treating a patient with these drugs to monitor for both of these issues, because the combination of hypoxia, anemia can put a patient at high risk for cardiopulmonary decompensation, such as pulmonary edema and risk of heart failure.
So I think that wraps up our discussion, so we will end with some bottom lines. Metastatic renal cell carcinoma is a very heterogeneous disease, and there are a few different risk scores, particularly the IMDC or the MSKCC risk algorithms that can help you stratify your patient and determine the need for treatment.
Patients with favorable risk factors, although you could consider systemic therapy, keep in mind that many of these patients may be able to be monitored for a period of time off of systemic therapy, maximizing quality of life and not impacting on their quantity of life.
If you do end up needing treatment, most patients will end up getting VEGF inhibitor plus immunotherapy combinations, such as pembrolizumab axitinib, nivolumab cabozantinib, or lenvatinib pembrolizumab. And these all have never been directly compared to each other, but seem fairly similar in their own respective trials.
Pay attention to the oral agent-drug interactions, which may sway you between one combination or another, depending on your individual patient risk factors.
Another combination that can be considered is the combination of ipilimumab and nivolumab, particularly for higher risk patients given the increased toxicities. Patients with oligometastatic disease are eligible for complete metastectomy, so removing all sites of metastatic disease, as well as nephrectomy, with the option of adjuvant pembrolizumab. The role of cytoreductive nephrectomy in people with diffusely metastatic disease has been questioned in the era of modern treatments.
For patients with oligometastatic disease that's not amenable to a surgical resection, don't forget to utilize other localized therapies such as ablation or radiation, which may also provide time away from systemic therapy.
And for people who progress on first-line therapy, options for second-line therapy include either changing the VEGF inhibitor, adding immunotherapy if not given upfront, or using the novel agent belzutifan, noting its toxicities such as anemia and hypoxia.
This drug has been approved for less than a year in the US at the time of our recording, and so certainly pay attention to evolving toxicity assessments as we learn more about this drug in the real-world practice.
So that wraps up our discussion on kidney cancer, but stay tuned for our next discussion on germ cell tumors, which tend to not be seen in the clinic as frequently in my experience, but can be high yields for board exams.
Thank you to all who've been listening along. Please continue to provide any feedback. We're trying to keep this podcast relevant and useful to all of those who continue to listen.
Hope everyone's enjoying their summer and enjoying the Olympics.
Go Canada.
Take care. For more information, follow us on Twitter at Talking Tumors, or feel free to email us at talkingabouttumors@gmail.com.
Please rate and review the podcast. We really appreciate it.
And special shout out to our friend John Kim for all of his musical talents.
And he is the composer of the music that you're hearing right now. Talking About Tumors is not medical advice.
For medical advice, please contact your own healthcare provider.
Opinions stated on this podcast are by the Ryan who said it and no one else. We have no financial disclosures, and this is done purely on our own time to the sake of our enjoyment of the field of medical oncology. Thank you for listening, and see you next time.